Hello, everyone. I'm really sorry I can't be there today, but I've recorded this for you, so hopefully you'll find it interesting, and you can also um, go back and review it because I'll be popping it on my YouTube channel and probably my women's health group as well. So, just to introduce myself, my name is Gail Jordan. Um, I am here from Align Osteopathy. So we are a small multidisciplinary health clinic specialising in women's health and paediatrics. We're located in Totton in Southampton. We've been established for since 2019, and our focus is on education, empowerment of our patients through functional healthcare and holistic healthcare. Um, you can see a couple of our patients. Obviously, the little baby that's smiling at you in the middle doesn't work with us. She's one of our patients, but I'm there on the left-hand bottom corner. That's me. The top meditating is Patina. She is our complementary healthcare practitioner. She's a registered mental health nurse, yoga practitioner. She does reflexology, reproductive reflexology, aromatherapy, that sort of thing. Then we have Sarah down in the bottom right hand corner. She is our paediatric specialist. She trained in France, so she's fantastic with cranial and visceral osteopathy, and also works a lot with our female patients. We do treat men as well, but we tend to, because of our knowledge base, we tend to focus on women. So a little bit about me. I trained in the London School of Osteopathy. I have a master's degree in osteopathy. I've been a complementary therapist for over 25 years, and spent over 20 years of that in education. So actually, education of everyone is really, really important to me. Um, I have a special interest in women's health, and I've done various postgraduate courses, registered mummy MOT practitioner, so that's postnatal rehab and examination, and as well as a postgraduate diploma in women's health osteopathy. So we're going to be talking about the pelvic floor today and pelvic floor dysfunction. But before we do that, I wanted to do a little recap of the female pelvic organs. As you can see, this is a cross section of a female pelvis, and I just want to, don't worry about all this around the outside. I just want to orientate you because I'm going to be talking a little bit about why we get these issues, and if you know this, it makes it a little bit easier. So we can see here, this is a bone, and then we've got the bone of the pelvis, sorry, and then we've got the spine coming up, the sacrum and the coccyx here. So the other half of the pelvis is been taken away in this diagram. So these are bony bits here and here. In between, we have at the front our bladder. Now the bladder sits just behind the front of the pelvis. And obviously coming from the bladder, we have a little tube called the urethra. Oh, sorry, I'll go back. Called the urethra. And that's obviously where the urine comes out, it exits our body. Nestled snugly behind that and sitting just on top is our uterus. So we can see the muscular sac of the uterus here, just sitting on top of the bladder. The tube coming just behind is the vagina, and then we have the vaginal opening down at the bottom. Behind that, again, it's all pretty snug. We have the anus and the anal opening. So this is where our waste sits before it's excreted from the body in the form of feces. So it is quite, it's quite tightly packed down there. So the pelvic floor isn't shown on this diagram, but I want to sort of orientate you. Pelvic floor attaches from the front here through this area and attaches to the coccyx at the back. So actually, a woman's pelvic floor has 3 openings going through it. So that's what makes it a bit weaker, because we have, it's not continual fibres. There are openings. So that's one of the possible reasons why we get so many issues with our pelvic floor. So why are we so concerned with the pelvic floor? Um, a lot of you may be thinking about sort of urinary leakage issues and that connection, but there are lots of things that can happen with a pelvic floor dysfunction. The first one is prolapse. That's probably the one that people worry about the most, and I'll talk a little bit about prolapse a little bit later in the video and what it is, because some people might not know, so we'll orientate ourselves with that in a little bit. Bladder and bowel leakage and urgency, so that's another major concern for people. And something that people don't tend to talk about very much is the inability to hold wind. And what you might not know is that back pain and abdominal pain can be a sign of pelvic floor dysfunction, as well as vulval pain and a dragging feeling around the vaginal area. Pain during sex and the inability to orgasm are another issue that people with a pelvic floor dysfunction may suffer with. Hip pain, recurrent urinary tract infections or thrush, and reduced vaginal sensation. So there's quite a big list there. It's not just, perhaps what you might think is just a bit of leakage or the prolapse issue. There's lots of other things that people can be suffering with that they might not know it's anything to do with the pelvic floor. So this is our pelvic floor. So if I just orientate you, we're looking down into the pelvic bowl. This is the beginning of your spine. This is a bone called the sacrum, and then your spine stacks up on top of this bone here. We have our pelvis coming round to form a ring, and that's the pubis at the front, and our hips, obviously, joints will be either side here and here. This in the middle here, that's the pelvic floor muscle or muscles. It's a group of muscles, and you can see some definition lines through it. So it isn't just one muscle, there's a group, but they just generally do work in unison. And it's not a very thick muscle. It's quite thin when you look at it. When I've been to dissections and we've looked at the thickness of it, it's actually quite a thin muscle. And it isn't necessarily designed for us to be contracting it all the time. It's supposed to work really, really nice on its own by flexing and movement. Our pelvic floor has to be quite bouncy to be able to put up with the pressures that we put on it through running and jumping and walking and all the other things that we do. And it also helps support everything else sort of going up, really. And if we have a tension one side or we have some issues one side, those muscles will pull, won't work so well, and that will affect the other. So it's really quite an important muscle group. So most people, as I said, are concerned with urinary leakage and possibly bowel leakage. It's again something that people don't talk about, but that is something that's quite common as well. So when we go through perimenopause and menopause, the bladder lining and the endopelvic fascia, that's the tissues surrounding the bladder in the pelvis, can become affected because there are lots of receptors on those tissues for estrogen, and estrogen is really important. And when that lack of estrogen starts to sort of affect our body and our muscles, it means that those muscles tend to become a little bit weaker. So that happens with the muscles and the tissues around the area. And also it can irritate the lining as well. So there is some debate around this, but that's one of the things that they think are happening at the moment. That's why women tend to get bladder issues with peri and postmenopause. So one thing I wanted to highlight to you, for those of you going through perimenopause or considering taking HRT medication, there is some evidence to suggest that actually oral HRT is linked to new onset bladder dysfunction, whereas the topical estrogen in combination with pelvic rehab seems to be the best for bladder health. Now, taking HRT on its own possibly won't cure bladder issues. You would probably need some support with that, but it is good to note that actually the topical HRT through gels applied to the vaginal area or onto the skin or the patches are the better option if there is a concern around bladder dysfunction. So let's just talk a little bit about the different types of incontinence, bladder incontinence, because that's the main concern for a lot of people. There are many reasons for incontinence, so these aren't just to do with your pelvic floor, so you need to make sure that Some of these perhaps are ruled out by your doctor, or if you're not getting anywhere with your pelvic rehab and HRT and all the other things, then you maybe need to have a little look and make sure there's nothing else going on. So we can have a neurogenic bladder dysfunction. That means that neurologically the bladder isn't being supported well. Urinary tract infections can cause incontinence, so that's important to make sure that that's treated if that's happening, because they can track up to the bladder and then in turn to the kidneys, which can potentially be quite serious. So urinary tract infections do need to be identified by your doctor and medication given. Vaginal infections or irritation and constipation. So again, some of these would need medical referral, so you would need to speak to your doctor about that. So there are different types of incontinence. So I want just to quickly go through what they are. So we have stress incontinence. So this is when urine leaks when you exert pressure on your bladder by coughing, sneezing, laughing, exercising, lifting something heavy. So the risk factors for this are menopause, as always, pregnancy and childbirth, particularly vaginal, but those of you that have had C-sections doesn't necessarily mean that you're not prone to this too, because of the scar tissue, which I'll talk about in a bit. Nerve injuries, connective tissue disorders like EDS, that's like hypermobility. So if you're someone that's really quite bendy naturally, then that can be a risk factor too. Obesity, pelvic surgery such as hysterectomy, chronic coughing, diabetes and uterine prolapse. Urge incontinence is when you have a sudden and intense urge to urinate. It doesn't necessarily leak, and that's followed by an involuntary loss of urine, but not always. So it might be that you just dying to go to the toilet, you have to run to the toilet, you might not always leak. You may need to urinate often, including through the night. So this may be caused by minor conditions such as infection, or more severe conditions such as a neurological disorder or diabetes. So if you do suffer with neurological issues and or diabetes or comorbidities, it will possibly increase your risk of having these incontinence issues. So risk factors are diabetes, again hysterectomy or other pelvic surgery, medications including antidepressants, diuretics and blood pressure medication. So if you are experiencing this and you are on any of these medications, it might be worth having a chat with your doctor or your pharmacist to see if there's anything that you can do about that, an alternative that might help. Menopause, neurological disorders like Alzheimer's, Parkinson's, that sort of thing, obesity, smoking and stroke. We then have mixed incontinence, so that's when you experience a bit of both, so a bit of urge, a bit of leakage, and that's just what that means. It means you do both. We then have overflow incontinence, so this is when you experience a frequent or constant dribbling of urine and the bladder doesn't empty completely. This is usually associated with over-distension of the bladder, or make the bladder being overfull, or obstruction of some kind. So we'll talk about that in a second. Obstruction, that basically means some sort of prolapse. So I've taken this diagram for you, this picture here, off the internet from the Pelvic Guru, because I thought it was a really good one. It sort of showed all the different types of prolapse, because prolapse basically means a pelvic organ moving into the space around the vagina and compressing on that area. So at the top on the left hand side, as you look, you can see the normal anatomy that we spoke about just a minute ago. To the right we have something called the cystocele. So this is basically where the bladder drops and compresses into the vaginal area. Now obviously it doesn't go through the vaginal wall, so when I examine my patients I would notice that then there would be, because obviously their urine lying up, face up, there would be something, a bit of tissue coming from above at the top of the vagina, and that's usually the bladder that's sort of pressing on that a little bit. If you look at this and you can see there's sort of a downward drag, this is something that can happen postnatally, because if you've given birth vaginally, think about that pressure of the baby exiting the vaginal canal, it all drags everything. So postnatally this is quite common. However, it can raise up and even itself out a little bit afterwards. So, most women have a little bit of this issue just after they've had a vaginal delivery. Then as we go down on the left hand side, we have something called the rectocele. So the rectocele is when the bowel protrudes into the vaginal space and it creates a little pocket or a fissure. And basically this can cause constipation or issues evacuating your bowels. Some women may have to support that little area where it's sort of bulging out and press on it to be able to defecate properly. And that's really common. So if you do that and haven't told anyone thinking, oh, I'm really strange for doing that, you're not. It's really, really common. And it's just where your bowel has sort of squished in towards the vagina and it's created this pocket. So that's where you have to sort of push it and relieve it. But as I said, the bowel itself doesn't protrude through the vaginal wall. It's just like a bulge, and I would see that usually from the bottom on my view on examination. To the right of that we have a uterine prolapse. So this is when the uterus itself descends into the vagina, and you would be able, this is quite easily seen, it's quite common, and this can compress on the bladder. And you can see that it's compressing quite a lot on the bladder there if you look at it compared to the anatomy without prolapse. So that compression will cause some perhaps leakage or some urgency issues. The bottom two are really only when you've had pelvic surgery, so something like a hysterectomy, so that your uterus has gone, and for example the one on the left is the enterocele, is where your intestines have basically drooped into the area to fill the gap of where your uterus is and then dropped further. And then the vaginal vault prolapse is when the vagina itself starts to descend into the vaginal opening. So they, as I said, they can happen when you've had a hysterectomy. So NICE guidelines. So these are the guidelines that National Clinical Excellence guidelines. This is what medical professionals should be working towards. So they recommend, if you have any of these issues, then lifestyle interventions are the first thing that you should undertake. And these are what we're going to be talking about, some of these in a second. Things like caffeine reduction, because caffeine can be an irritant, modifying your fluid intake, which I don't necessarily like the idea of. I don't like when my patients come to me and tell me they're not drinking, because that has other effects on the body. Reducing weight. Now, there is quite a lot of fat phobia around. Everything's blamed on weight, but weight will cause a pressure on your pelvic organs and on your body. So if you can reduce that weight, then it possibly will help. Improve your fibre intake to aid constipation. We'll talk about that in a bit as well. So pelvic floor muscle training is recommended for at least 3 months. So they recommend that you should do at least 8 contractions 3 times a day, but that's quite hard for people to undertake. So I just tend to get my patients to do 10 with different exercises daily, and that tends to be quite good for them. Behavioural therapies like bladder training, lasting of a minimum of 6 weeks as a first-line treatment with urgency and mixed urinary incontinence. So what can we do? The current evidence suggests that the muscles and fascia of the lumbopelvic region, that's the back and the pelvis, play a significant role in the musculoskeletal function of the pelvic floor, as well as the respiration as well. So this is where I come in, this is what I do. So what we try and do is help to balance the tissues and balance the mechanisms so there's less pressure. There was also a study undertaken in 2021 that compared just pelvic floor training alone to pelvic floor training and connective tissue massage, really, that's what they call it, but it's connective tissue therapy, so sort of osteopathy, perhaps chiropractic massage, things like that. And it helps to give superior outcomes to reducing an overactive bladder. So, what factors do I look at that I feel influence pelvic floor dysfunction? So when I say pelvic floor dysfunction, I'm talking about the pelvic floor not being able to work properly to support those pelvic organs. So the first and most important is scar tissue. So scar tissue is the worst. It affects so many of my patients, and it's not just C-section scars, which we can see here. It's episiotomy scars, it's scars from keyhole surgery, it's scars from appendicitis or hysterectomy. And so the scar tissue really does have a massive impact, because when you cut into skin, the body wants to, and the layers underneath, fascia, muscle, the body wants to heal it as quickly as possible. So it forms scar tissue, which is a bit haphazard. it's thicker, less mobile than all the tissues that were there before, and everything can become a bit sticky around it. So if you've got an area that isn't moving and flowing and sliding as well, it's going to pull and drag, and then everything around that area will then start to compensate and be tight and pull and drag. And that dragging, does that sound familiar? Yes, it does. It will drag, giving that dragging sensation down to the vagina. It can pull the pelvic floor tissue to perhaps one side and cause alignment issues. So it is really important to work on scar tissue. So I'm going to show you some techniques in another slide or so that you can start to work on your scar tissue if you have any. And it doesn't matter how old it is. Now, bearing in mind, you don't want to be working on scar tissue directly after an operation, but as soon as it's sort of knitted together properly and healed, you can start working on it. So really gently right around the area rather than over the scar tissue. But as I said, we'll talk about that in a second. Muscle weakness due to sarcopenia. So sarcopenia is loss of muscle strength and bulk and tone as we age, when we get older and do the training accordingly to keep ourselves strong. Dysfunctional breathing mechanisms. So this is when, our breathing is not right. Well, most of us probably will be like this. We breathe up into our upper body and we don't use our diaphragm correctly. And I'll talk about how important that is and why in a second. Constipation, hip dysfunction. So if your hips aren't functioning well and the muscles around them are tight, this will directly impact the pelvic floor. So there's some of the internal hip muscles connect with the pelvic floor, so if they're tight, that will pull and cause tension and dysfunction through the pelvic floor. As mentioned before, hypermobility and EDS. So if you are hypermobile, this makes everything a little bit difficult and makes all your tissues a little bit more mobile, so they don't function as well. It's harder to keep everything where it needs to be. And also, as I said, complementary holistic therapies are something that I feel are really important, and within that we look on the mental aspect of our well-being, and trauma and psychological issues surrounding the pelvis, the pelvic floor, are some of the most troublesome and problematic with regards to hypertonicity or tension through the pelvic floor. So that does need to be addressed as well. If you are someone that you've had a trauma, birth trauma, other traumas surrounding that area, it is important to think about that as well, because that can impact how it works. Right, so scar tissue massage. So I found a couple of nice pictures on the internet that might help you here. So it's basically just mobilizing the tissue as best you can. And this is obviously showing on the abdomen, but you need to do this around, if you have episiotomy scars through childbirth, then you need to do this around there. So internally as well as externally. So it is really, really important. If anybody wants some information on the internal massage, I've got a NHS handout that I send to some of my patients to help them. You are more than welcome to contact me after this. I've got my details at the end of the slides and I can send it to you. But obviously I'm not going to put that on here. Oh, keeping the muscles and bones strong. Goodness me, this is so important. So from the age of 30, we lose between 3 to 8% of our muscle mass per decade. And I actually, there is some evidence to suggest it's more than that. So we lose 40% of our muscle mass between the age of 20 to 80. That's a huge amount. And remember, our pelvic floor is a muscle. Our diaphragm is a muscle. How we get around is by using muscles. So to make sure we can keep mobile and strong, then, working out with strength training is really important. And it's important for our bone density as well, because once we go through menopause, that lack of estrogen again affects our bones. So we become less dense through the bone tissue. And to help with prevention or management of things like osteopenia and osteoporosis, then strength training is important. Building muscle can also help maintain testosterone levels, which helps with our libido and other things. I'm not doing hormones today. That's a whole nother lesson, but that's quite important. So if any of you are perhaps lacking some libido, then get strength training. That will help. And some interesting information I found is that there is evidence to suggest that high levels of cardio with no strength training, so that's just running long distances, can lower testosterone and also lower our muscle mass. So basically work those glutes, everyone, because they're connected to the hips and the pelvic floor, and they're great for keeping us strong and helping with back pain. But do, some strength training. So I've got a couple of little pictures here. Kettlebells, fantastic, using free weights, or you can just use your body weight. That's absolutely fine. So, breathing mechanics. Without going into lots of detail, I've drawn a couple of pictures here. I hope you can sort of see what they are. So I wanted to show you the diaphragm or the diaphragms in breathing. So this up here represents the thoracic diaphragm. So when we breathe, our diaphragm's a muscle that cuts between our abdomen and our thorax, so where our lungs are. It's a flat muscle, again, like the pelvic floor. Its contraction helps us or allows us to bring in air. When we breathe in, we contract the diaphragm, which is here just under the ribs. It pulls down and we take breath in. So the pelvic floor is actually a diaphragm as well, and that moves in conjunction with your thoracic diaphragm. So when you take a breath in, this diaphragm comes down and the pelvic floor diaphragm comes down and pushes down. So what we don't want is for us to be exerting any more force going down into these pelvic floor organs when we do that. So we need to make sure that when we exert ourselves, we're not breathing in, because the pelvic diaphragm is pushing down and opening, and there's a lot of force in that area, so we don't want it to be causing us to have a prolapse, which I'll talk to you in a second about how we can affect that. So in breath needs to include your tummy. So most of us breathe up here. When we take a deep breath in, we up into our chest, because we've been taught over the years to sort of hold our tummies in, and that's how you breathe. But actually, that's really not great breathing, because what happens when you breathe up into your upper thorax is that you use your accessory breathing muscles. When we breathe in, when we're not exerting ourselves, we should only really use the diaphragm and some muscles in between our ribs. But when we breathe in into the upper body, we start using muscles around our neck and shoulders, and then we also use them for their everyday use, and then we also use them more when we work at a desk and lean over. So our upper back and our shoulders and neck become really, really tight and overused because we are not breathing properly. So when you breathe, you need to push out your tummy. So the diaphragm has somewhere to go, because obviously you've got all your intestines and your stomach and that here. So that needs to come out, because we don't want anything else pushing down onto this pelvic floor. I'm hoping that makes sense. So when we breathe out, the thoracic diaphragm goes up, takes the pressure off of these abdominal and pelvic organs, and the pelvic floor also goes up. So this is the perfect time to put stress through the body through lifting. Okay, we'll talk about that now. So here we have quite a nice diagram here from the Continence Foundation of Australia. I thought this is a really nice one to sort of show you what I've been talking about. So by breathing in through our tummy and easy breathing, it releases the pressure from our pelvic organs, because we don't want them being pushed down. If you hold your breath, it pushes down, can you see here, on this pelvic floor, but we've got all these organs in the way. We've got the bladder and the uterus and the anus here. So it's pushing down on them and pushing them into areas of least resistance, which are the holes. So that's really what's happening when a prolapse happens. So let's just recap again. So, when we take a deep breath and we don't allow this muscle to move, we don't allow space, we push down on all of these. And especially if we're leaning forward as well, can you see that uterus there? It's going to push down on the bladder. It's going to push, everything's going to push down into these exit holes. So it's really important to balance these pressures. So, stools. Okay, stool consistency is key, because talk about pressure on the pelvic floor. If you are constipated and you have to push out your feces with force, that's going to again put a lot of pressure on that pelvic floor and cause dysfunction. So, stool consistency is key. We need you to be aiming for around type 3 and 4 on the Bristol stool chart here. So type 1 is like pebbly, sort of little rabbit poos. Type 2 is a really hard sausage. This is where you're in the realms of having to sort of put a lot of force and constipation to get that stool out. But again here, coming down to these lower aspects, also not great to have lots of watery stools, because you'll probably do that more often. It means that you're sort of going to the toilet and pushing waste out more often. So it's really important to try and get a really nice balance here. Now, I know that for a lot of you, this may be an issue with things like IBS, so I've given you a couple of ideas to help. The one that I haven't put on here actually is really actually important is stress. Stress has a massive impact on our gut. And if we are constantly living in a stressed fight or flight response, then it will make us have gut issues, and it will make us not digest our food properly, and it will make us have things like diarrhea. But here are some other tips. So drink plenty of fluids. Now, you probably don't want to do that if you are having problems with leakage, but it is important, again, to soften up those stools. So, it's a cycle that can cause it to sort of spiral out of control. So we do need to make sure you're getting fluids. You don't have to drink lots and lots of water all the time. You can do it by eating watery fruit, and the fibre in the fruit will help with the stools as well. Eat a diet high in plant fibre. Identify possible irritants. So there are things that can be quite irritating to the bowel and to the gut. I think onion and garlic are some. A lot of people feel that they're allergic to things like gluten, but actually sometimes it's the sugars. So fructose, lactose, milk can be an issue. So just try, and it's different for everyone. Some people are absolutely fine with these, but just try and make a note. If you are having bowel issues, try and make a note of what possibly might be causing that with your diet, and just try and amend it. Good gut health is really, really important. So having a really good course of probiotics every now and again, especially if you've had antibiotics, for those of you that are suffering with the urine infections. Keeping that gut bacteria varied and at a good level will help with the formation of stools, but it's also starting to be linked with mental health, things like diabetes, obesity. So really do look into your gut health if you've got problems in those areas as well. And then finally, move. By movement and breathing properly, we are massaging our bowels as we move, and that can help move everything around the body and expel effectively. Right, so pelvic floor exercises. So some of you may be doing them at the moment, some of you may be unsure if you're doing them, some of you may be doing them and they've done absolutely nothing. Everyone is individual. Some people think that pelvic floor exercises are completely useless. Some people think that they're the only thing you should do, but actually I feel that it really depends on the person and that individual's body and what they've been through and what they're going through at that moment. I want to make you aware that relaxation is as important as contraction. If a pelvic floor is tight, over-exercising can worsen your symptoms. So if you can, and I do realise that, it's difficult sometimes financially, but if you can, go and see a pelvic health specialist to just have a little look and do an examination, so it's usually an internal examination, that will help you identify whether you've got a dysfunctional pelvic floor because it's too tight and not been able to move, or you can't control it and you haven't connect that connection, or it's a bit weak. It is quite important to know that. However, I do understand that private healthcare is expensive. You're not very likely to get this through your GP if it's just curiosity. If you have quite significant pelvic problems, then you probably will get referred. But it's worth a try. But if you can seek someone privately, then that'll be fantastic. However, I've given you some tips in here of other things that you can do. Okay. So let's talk about getting a good pelvic floor contraction and relaxation. Contraction of the pelvic floor is better when breathing out. So we know that now because of the pressures. So the pressure on the pelvic floor is less, and also the natural movement of the pelvic floor as you breathe out should bring it up and contract it. Okay, so use your breathing or your natural breathing mechanics when contracting your pelvic floor. So contraction on breathing out. I know that seems a bit strange, but it is much better. Belly breathing, belly breath, to use your diaphragm properly. So when you breathe in, your belly should move out at the same time. So that if you want to do this now while I'm talking to you, pop your hand on your belly, take a deep breath in, try not to go up into your shoulders. Your shoulders shouldn't be moving up, but your belly button and your belly should be moving out into your hand. Okay, so that's your belly breathing. Don't just squeeze your glutes. The amount of patients that come and I assess their pelvic floor, all they're doing is contracting their glutes. They're not contracting the muscles. Contraction should be inside. You should be able to stand and have a chat with people, and you should be able to stand at a bus stop and contract your pelvic floor without everyone seeing your bottom clenching. Make sure you fully relax after each contraction. So relaxation, as I said, is very, very important, because if you work any other muscle that's half contracted all the time, you don't get a full workout. So actually, to really work that muscle, you need to be able to relax it. But also, relaxation is very important too, because we want our pelvic floor to bounce. We want you to be bouncy, so you've got a lot of shock absorption. So using visualization will help, and I will talk to you about that in a second. Think about trying to hold in a wee, or try to hold in a poo, and that's how will help you focus where your contraction is. Most people get a better all over contraction of the pelvic floor through trying to stop a poo, basically. So it's that anal, around the anal area, so contracting around there, and you should feel it draw up into your tummy. So instead of just contracting the muscles where they are, try and draw it up into your abdomen, and I'll explain that through visualization in a second. Perform your pelvic floor exercises, contraction and relaxation, in different positions. So it's no use just laying down on your bed doing your pelvic floor contractions, because your pelvic floor is an anti-gravity muscle and you need the gravity there for it to have resistance. So do it in different positions. So on all fours, standing, and also when strength training, but make sure that you're doing the breath. When you exert force, breathe out, do the exercise on the out breath and your pelvic floor contraction at the same time. If you can, as I said, get a professional to examine you and help. So some things like mummy MOT, if you've had children, are very good, but there is no cut-off date for how long ago you've had children. And I also offer pelvic myself, and you'll get this with other physiotherapists and osteopaths that do women's health, pelvic health sessions, where that will be included as well. You don't necessarily have had to have children, or you don't have to have had children to have your pelvic floor examined, but these are some of the things that you could look at to do if you can. Right, so that visualization, the first one I get my patients to think about on contraction of the pelvic floor is an elephant's trunk picking up a peanut and bringing it up into their mouth. That's what I want you to think about when you are doing a pelvic floor contraction. So basically your entrance to your vagina is your elephant's trunk coming up and drawing up into your tummy. So you should feel some pull up into the abdomen. The other two here are for relaxation. So thinking about how a jellyfish moves through the water, it sort of pulsates and opens and closes that sort of hood. That's what I want you to think about when you are trying to relax your pelvic floor. So that opening of a jellyfish or opening of a flower blossoming, just letting everything relax. And when you think that you are relaxed, just then try and relax the muscles of your glutes and your legs and your back, and really try and make sure everything is really nice and relaxed, and then do it again, that opening. Okay. So this is something else that you could look at. It's private training, but I went on a course with Nikki from UK Hyperpressives, and she developed a training program to help to reduce the pressure on the pelvic organs through breathing and yoga techniques. So it's strengthening to the posture, it's decompressing to the pelvic organs, and you can use this if you have tension through the pelvic floor, because you might not necessarily want to train that pelvic floor. You want to relax it and take the pressure off. So this hyperpressive type breathing will help. So it feeds into sort of what we do as osteopaths with the breathing techniques and reduction of pressure through manual therapy and manipulation. But it's like a class, and she does it online. So if you can, check her out. She does some free stuff too, some free course classes and online stuff. She's very good, but she's definitely not one for liking the pelvic floor squeezes. But she is fantastic. So I'm hoping that's been interesting for you, and you've got some ideas of how you can help yourself, how you can keep your pelvic floor functioning well, or where you could go if you need some additional support. You are very welcome to contact me. So this is my email, gail@alignosteopathy.co.uk. You can WhatsApp me through my mobile number. You can go on my website and have a look at what we do. There's a chat function on there. Also on Facebook. Oh, I forgot to put the rest of my Facebook address down there. Or on Facebook, I have a Facebook group, Align Women's Health, which I'm probably going to put this video in. And I'm also on Instagram. Anything else? Possibly you can you can contact me in lots of different ways. I'm very open and to questions. And, if I don't know the answer, I will help you find it. So I'm going to sign off. I hope you enjoyed it. Thank you so much if you've got to the end and listened to my rambling. I really do appreciate it. And hopefully this will make everything a little bit better for you. Thank you. Bye.